Thank you very much again. Now we go on with the last lecture of this morning, and I'm very happy I'm very happy to present the Percutaneous cervical cordotomy to you, because as the former speaker, Dr. Pascal already showed you, it is really very effective. It is, let's say, the number needed to treat is almost 1. And that's, I've never seen in my life a result, an outcome from any procedure except from the percutaneous cordotomy. So when I attended the first Congress on Pain in Florence in 1975, I met Dr. Sam Lipton, and he taught me the cordotomy, and also the late Menno Sluiter taught me in 1976, 1977, when he was still working in Amsterdam. He taught me to do the percutaneous cordotomy. Since then, I may have done almost 900 cordotomies in my life, and the results were and are astonishing. So, it's the only valuable procedure for the unilateral pain due to malignancy. And of course, in my former hospital, this is also the instruction for the patient information. It's always very important to give information to the patient for any treatment you do. And especially in the cordotomy, as the pain is single-sided, the procedure will be on the other side. And I'll tell you why, and you already know it, of course. This is to show you, and you have seen it in the Swedish, Adam Pascal told you that it is more than 90% of the patients have good to excellent results. And the most important thing, let me see, is there a pointer? Right. Is, we talked about opioids, we talked about medicine, but the most important thing is that cancer pain patients can live their life out free of pain and dignity. And we have all seen the high doses of opioids leveling up, titrating up. You know, Professor Cypher told us 90 milligrams a day, but I've seen thousands of milligrams a day, and they changed it to intrathecal morphine, but you have opioids, but you have the same problems. In the end, the patient is just lying down, and these days they call it a kind of slow euthanasia. The patient cannot watch TV, cannot read any newspaper, cannot see, is sleeping, and everyone is waiting for his death or her death. So that can be avoided. Here you see it has already a long history. And today it is still a kind of same procedure. In the past, neurosurgeons cut your skin and then they make a lesion with a knife in the spinal cord. Nowadays, we do it with a small needle and radio frequency probe on the right spot. This is a little bit sad for me, because when the patches, the opioid patches were, let's say, discovered in the late 80s and used widely, then every oncologist, other doctors, they just put the patch on the patients, you know, with the result I told you before. There were a few opportunities anyway to master the technique, although basically it is not a very difficult procedure. The only thing is that the technique is quite understandable and safe. The only thing is that I told you I've done many of those patients with cordotomies. There was not one single patient the same. So you need some more experience because you did not have a direct vision. And especially in the elderly patients, there is some torsion of the spinal cord. You get a bloody tap, for example. The patient is laying down in front of you, normally cannot lay down if you have a pancreas tumor. It's very painful to lay flat. So you have to hurry up a little bit the procedure. So this all kind of things make doctors a little bit reluctant to do the procedure. And they are afraid of, let's say, hitting the motoric branches and then cause a paralyzed patient. So this technique was on the way out. I performed most of my cordotomies in the late century, and as Professor Haver will agree that last years it was a diminishing number. But now, with all the rumors about the opioids, you know, in the United States, many patients, you know, are addicted and so on, and so on, and so on. So now, we are looking again into these kind of procedures. And that's what I like. So here you see the pathway, and of course the pain runs, see, the pain runs to the spinal thalamic tract. And the spinal thalamic tract is for the so-called vital pain, that is pain and temperature. Nothing else. So when you do the procedure, that's remarkable, the patient will feel no pain, or at least a reduced pain. And the temperature will be reduced too. But he's still feeling everything. So the normal sensitivity stays normal. The only thing is you have to warn the patient when he goes, for example, under the shower, to feel the water, if it is, you know, with his right hand or left hand, depending on your side of cordotomy, to feel if it is hot or not. Otherwise, he could get burned. So what is the technique in itself? So here is the spinal thalamic tract. So this is on the ventral side, on the cord of the ventral side of the patient. Now, you don't want to be in this area, because there you may produce a spinal cord lesion and paralysis or paralysis. So what we do as a landmark, yes, we have, sorry, the former. The technique is anterior to the dentate ligament. And we use a soluble contrast medium that is liquid gold, that is an oil charactered contrast. And you know why we don't use the water contrast, water-based contrast, is because that is flowing away in the cerebrospinal fluid. because the cervical fluid is caused, of course, it's with the heart of the beat, it's going like this, so you lose your point. With the oil, it sticks in the region on the side of the dental ligament. So this is where you want to be, here. And you can see here, this is for more the cervical. If you are more experienced, you can even do a high selective cordotomy. Because if you have, let's say, a penclosed tumor, then you want to be at a higher level. If you have some carcinoma in the leg, you want to be a little bit more here. That can be done. It's not especially needed. If you have this, you have almost all. It's the single-sided. So it is a radio frequency heat lesion, as I told you, at the C1, C2 level. That is because there is a gothic arch, and between the gothic arch you have a nice entrance to the spinal cord on that level. And as they cross over, this is very important, you use the opposite side. Well, the indications you can see here, life expectancy less than 1.5 years. The reason for that is that you may develop a kind of post-bottoming dysesthesia, but that is never happening before 1.5 years. C4 is the maximum. So if you are at higher levels with pain complaints, you are not advised to do the treatment. Nociceptive and neuropathic pain, as you can see. Contraindications. Well, anticoagulants is a little bit, if you have aspirin, acid, that we just continue. But if you have more other coagulants, you just follow the principles in your hospital. Non-malignant pain is absolutely not done. In the past, it was this procedure was performed for, let's say, post-herpetic neuralgia, which can be very nasty and untreatable. So people try to do that, but no good idea. So this is the position. Yes, horizontal. The patient has to be rather flat, otherwise your contrast medium will either go up or go down. As you can see here, this is a little bit local anesthesia. When I give the local anesthesia, I already look at the needle, to go to the ventral side. Normally it's always in the middle, the dental ligament, between the corpus and the pedicles. It's always here, depending a little bit on the arch. Yeah. Now here you see the spinal fluid, cerebrospinal fluid coming out. Then after that, you have this contrast medium injected. So then normally you find 3 lines. The anterior level is the ventral side, is the top of the spinal cord, and the second line is the dentate ligament, and the third line is the bottom of the spinal column. So as you see here, this is the dentate ligament. this is the upper side of the spinal cord. Here you see it again, dentate ligament. It's a landmark for cordotomy. Here you see the procedure, so when I identify the dentate ligament, we introduce the RF probe, and then you go for the controls. And the controls will be, let's say that you have first the sensitivity, you are testing here, you see it. So you're testing at high frequency, you are testing the sensitivity, and at a very low frequency, you are testing, and higher voltage, you are testing the motoric. So what you actually see is easy. The point is that the patient is laying there. So when you start stimulating, please tell the patient, when you ask, because you are going to ask the patient, where do you feel the prickling? Where do you feel it? If you feel something, just say yes. Don't point at it, you know, but because the needle is in place and everything is a little bit covered with sterile sleeves, etc. So you don't want the patient to move. And so you just say yes, and then you say, do you feel it on the right or the left side? Normally, if you perform it on the left side, of course, the patient has to feel it on the contralateral side. Yeah. So if the patient feels it on the contralateral side, that could be a little bit more heat or prickly, and then you are already where you have to be. But then you have to test the motoric on the low frequency. And then the normal reaction is this, on the homolateral side. And if you see this, and whenever you do this procedure, if both controls are okay, then you know that you will succeed in making the patient pain-free. There are, of course, variations, that you have a good sensitivity, but not a good motoric. The patient is good, for example, this. Then you are probably a little bit on the too safe end. So, but normally it's 80% is just like this. So then, the procedure you see here, 97 degrees, and a little bit different what probe you use. I use normally a Levine probe. There are other RF probes, so they have a little bit different qualities, but the Levine probe, you do 15 seconds, 97 degrees, and what you do then is you have a pinprick. Yeah, so you prick with the needle on the painful side, and you ask the patient, does it prick or is it thin? No, when it is thin, then you know, okay, I have already done this. Then I take a bigger needle and I prick it through the skin, so deeper, and I ask it again. Because sometimes there is some edema around the lesion you have just made, and that may diminish in due time. So then, most of the times, I do another 10 seconds. When the first is already good, I use 10 seconds. So here you can see it. I use the pinprick. You see this was the answer of the breast. But you see the pinprick, and then I just control the motoric. You know, I ask the patient, can you lift your legs? So we saw some publications from Arun. And these are two Dutch results. And you see Ben Krul, he published 43 patients, and you see good results in 95%. So a little bit more than the 92 you presented. And at the end of life, still good results at about 70%. Yeah. There was even a better study, I think, from Paul Somers, I think together with Frank Harter. And you see, he just made 52 consecutive patients. He reported the numeric rating scale, and his indication was it should be above 5, despite maximum conservative treatment. That means also opioids. The pain relief was intense, from 9 to 0. That's impressive. And the opioid use was very well reduced in the end. And in the end of life, still good results of 83%. Only mild complications, even in the hospital, anxiety, depression score, etc., there were no differences. Some complications, high temperature, yes. Don't be worried, that is almost always within the 24 hours. And if you are not on duty and someone is on duty, they say, oh, there might be an infection or something, but it's not. It is just the first day. Bladder temporary functions, I have not seen too much. Maybe 1 or 2, or, you know. You have, of course, the patient has to go to the recovery room and can leave the recovery room after having, let's say, empty the bladder. So, motor weakness, yes, in some cases. This is from the literature. This is not my results. Pain recurrence, could be technical errors, etc. Mirror pain, yes. I've seen some cases of mirror pain, and that is quite interesting. And I'm looking to Marshall Devore, because I think I don't know why this happened. We were thinking that the tumor may be extended, some scar tissue might pull the pleurae or whatever, but I think it is a kind of habituation, a default habituation to a former experience of pain. But that's another story. So the conclusion is, no other intervention or pain procedure available, repeated. Now, what is the problem? As I told you, it is a skillful technique is needed. Radiofrequency in the spinal cord makes the doctors nervous. Patches, epidural spinal pumps are easy to apply, no matter the quality of life. So, I thought that let's make the procedure more easy, that doctors are more confident. So that is, I use the 7-star scope to have a direct vision through the needle. For safer procedure, hopefully improving the results, but there are no studies about it. Less side effects, less complication, and easier to do to the benefit of the patient. So the needle, this is the kind of needle, and you can see here is the RF probe going in. Here is a fiber optic. The fibroid plate goes in together with the probe. So you can see it here. Fiber optic, and the refinement, in this case the refinement probe. Then you have, of course, I still do it also, here you have the picture, the direct vision, but I still use the CR. Here you see it. Again, I showed you the test, both sides, motoric and sensitivity. Anterior to the dentate ligament, the change of impedance, because you have low impedance when you are in the cerebrospinal fluid, when you enter the spinal cord, it will so this impedance go up. And here you see, for example, the views you have. Now this is interesting. This is a finding that sometimes people who do this procedure can have a bloody tap. Now, one of the reasons you don't know. Why is this? The dramatic thing about this is if you have a spinal tap, you almost have to give up the procedure. So then the patient, you know, is this terrifying thing. Here you see the reason. This is the pica artery, so the posterior inferior cerebral artery sometimes go down, and you could puncture it. Here you see the ventral roots going in, the radix radici. Here you see, with my scope, this is the insulated part, and here you see the electrode is already in the spinal cord. This is the dentate ligament. These are the ventral radix radici entering the spinal cord. So you see everything. You can't miss it. And here you see yes, there you go. Here you see it. You see the beat of the heart. Oh, sorry. Here you see can you make it work? Happy to see it again. Here you see the spinal cord. You see a little clot. You see the heart is beating and the spinal fluid goes like this. Here you see the puncturing at above the level, and here you see a small hole when I withdraw the needle. So, and this is, you see below, this is the dentate ligament. So hopefully that brings not only light for the doctors, but also a good future for our patients to treat. Thank you very much. Yes, are there any questions? Well then, thank you very much. You can always approach me when I'm around here if you have some questions. I'm delighted to answer you. So I wish you a good lunch and see you back in the afternoon.
I have a question.
Sure, yes?
Do you also do it bilaterally?
the past I've done this, and I was a little bit lucky that there were no complications, but the reason not to do the bilateral is that you can run into a so-called syndrome of online. And that means that you have both breathing centers, let's say also damaged a little bit, and then the body is not reacting on low oxygen levels, and at night the patient may die because he just stops breathing. And he gets the carbon dioxide anesthesia kind, and then he will die. So this was, and I must say, I've never done it in this century double-sided, but in the past I did. Now we are doing with better probes, the high selective, and maybe that is what you mean, Dr. Roloff, that when you do the high selective, maybe you could do both sides again, but I've never tried it.
And in the past, did you see the online syndrome?
Sorry?
In the past, did you see that online syndrome?
No, I've never seen it. I've never seen it. As Dr. Pascal also showed, and in the latest study also, there were only minor complications, and I must admit that I only had very few complications except one. And I still remember the patient because during the procedure it was sterilized in those days, the probe. So now we have disposables. And during the sterilization there was some break in the probe, and it broke in the spinal cord, and the lesion was extended. It was a hole like this on the MRI. So then the patient was indeed paralyzed on one side, and that was very sad.
And the second question about the mirror pain. I have seen it quite often, and I think it's more like a central mechanism in the brain, what's happening.
Yeah, could be.
I saw it pretty frequently.
I don't know. I think maybe Marshall could comment on this.
Perhaps Arun can tell me more.
Yeah, no, I think because of the mirror pain, I think it is a neuroplastic. One of the reasons I stopped doing cordotomy and it pushed further down my algorithm is because of the mirror pain. Because you do see the medicating, some patients have reported in after 3 months, as early as that. Do you do bilateral cordotomies?
I did it in the past, but I don't do it the last 5 years. I work on a clinic, so I don't do it.
The reason is that I think the conventional thinking is that if you're going on the affected side, you do at C1 to percutaneously. If you want to do the other side, you go at C6 level neurosurgically, so that you don't get the on-time curse. You do not do below C5. C6, that's what they do. The second bit is that if you have got that kind of bilateral pain or mainly visceral this thing, the other thing the neurosurgeons do is either cingulotomies, or which they are now doing endoscopically, or you can do midline myelotomy. Again, that is starting to come back in vogue.
Thank you.
Any other comments? Then again, I wish you a nice day. Thank you for being here.